Dr. Sheetal
Sheetal.
Nanaware. Impression cytology for suspicious ocular surface lesions, a modified method.
Good afternoon all. Today my topic is impression cytology for suspicious ocular surface lesion. So there are ocular surface tumors. It can be malignant, pre-malignant or benign lesions, and mostly it is arising from conjunctiva, limbus or cornea. It is mainly from squamous epithelia, melanocyte or lymphocytes, and slit lamp by microscopy, obviously by trained professional, frequently yields a correct diagnosis. So, and gold standard for that it is biopsy only, either incisional or excisional. So coming to cytology, ocular surface cytology, it can be performed by like several methods like spatula scraping, brush cytology or the impression cytology. So impression cytology, as we know, like from different technique, like basically by two, like cellulose acetate filter paper or the biopore membrane device. And like as we know, it is quite expensive. It is coming 2000 to 2.5K both in device and that paper also. What we do in that technique, like basically we will do like with papers, we will touch that conjunctiva or the cornea, and cells will be added to that surface and removed from the eye, and it will be processed further for analysis by various appropriate method for histology, immunohistology or the molecular analysis. So in day-to-day OPD, we can see like many patient coming with pterygium or pterygium mimicking, for example, like OSSN or the multiple ocular surface disorder without any underlying cause or like without determined cause. So for every suspicious case, we can't give antineoplastic agent also because it will be risky because of its side effect, and counseling also cumbersome for sometimes to patients also. It is medication and regular follow-up won't be done by patients, and even to plan for surgery and to wait for result of histopathology, it is also time consuming.
18.
So in our study, what we have done, like
30,
we have used like it is as we know, it is minimally invasive, innovative, fast, and the cost effective. So what we have done like it is patient who are coming to regular to our OPD. We have done in such patient after taking consent from them. We have used like 35 Watson filter paper, what we have used for Sharmas. So and we have taken that filter paper also, and we have taken that smear on slides also, and we have sent to laboratory with they have done fixating with 90% alcohol. So we have done like 15 to 20, as we have started it recently from 5 to 6 months only. So I have done like in 3 cases what we got, like for in first case it was 64-year-old female with status for pterygium excision done. We have collected samples. It was negative for malignant cells, and it was just showed like scattered unnucleated cells. Then patient underwent surgery. It came in biopsy like solar actinic changes suggestive of actinic keratosis. This is post-op pictures. Then one more patient, like 55-year-old female, male. He had like fleshy growth. We had done sample collection. On that impression cytology, we got low cellularity of scattered squamous epithelial cell and no atypia. And post-excisional biopsy, it came as like CN grade 1. Then one more recently we got in OPD. He had history of herpes zoster, and he has on and off treatment for stromal keratitis also. Like from 1 month he had having some granuloma formation. We also did sample collection. For that no cells are there. We have planned for that patient biopsy and not surgery. So as we can see, in case 1 it was suggestive of actinic keratosis, in case 2 it came like CIN grade 1, and in case 3 we are still depending on like biopsy for confirmation. So coming to conclusion, it is the like novel technique, then it is rapid, less invasive, it is also cost effective, and it can promote like fast innovation for better prognosis. So it is like very simple, easy to learn and handle, and for beginners also they can diagnose, and management also can be done with supervision, and it can be helpful in cutting off the waiting period with histopathology report in early stage. Thank you.
Have you compared this with the established methods of impression cytology which you referred to in your first slide?
No sir, we have
because
just
that is the way you need to compare. No, you're comparing it with histopathology, which is not correct. Impression cytology using Sharma's Whatman paper to impression cytology using the membrane micropore devices and other. That would be a valid comparison. Okay? Thank you.